Good morning, ladies and gentlemen. Welcome to this first webinar on organised by the World Health Organization on public health and policing and the commonalities and intersections between two very important disciplines. My name is Jonathan Passmore. I'm the Regional Advisor for Violence and Injury Prevention for WHO's European region. We have a very interesting and exciting discussion today. Before I hand over to our moderator for today's session, I just wanted to remind our audience, probably probably don't need any reminding, but about the Zoom functions. So we do have a Q&A function. Please, if you have any questions for the panelists, for the speaker, for the moderator, please send it into the put it into the Q&A rather than in the chat function. Excuse me. If you do have any logistical issues like technical problems, please use the chat function. So without any further ado, I'm going to hand over to our moderator for this session, Dr. Sean McGill from the UK Department of Health. Sean.
Thank you, Jonathan. Welcome everyone. My name is Sean McGill. I'm a specialty trainee in public health medicine and currently chair of the Public Health and Police Collaborative Group in England. So our first speaker today is Professor Nick Crofts. He is Honorary Professorial Fellow at the Nosal Institute, University of Melbourne, and Honorary Executive Director of the Global Law Enforcement and Public Health Association. So I shall hand over to Nick.
Thank you, Sean. I shall share my screen. Thank you. And from where I am, good evening, but I imagine good morning to most of the people on this webinar. Some of what I'm going to talk about will be basic 101 for a lot of people who are in this audience, I know. And some it'll be new to others. In fact, it's very patchy around the world. The development of this thinking about the need for law enforcement and public health to work together is very patchy. In the UK, I think it's probably more developed, and there's been more thought and progress than in most other parts of the world. And in some parts, many parts of the world, haven't even started thinking about the issues. So pardon me if I'm telling you things that you already know well. Now, what do I do to move to the next one? Do I do one of those? I do one of those. So as a basic introduction to the whole concept, we are increasingly recognizing the complexity of the issues that we face. And I think it's not just that I'm getting older, but I think the issues are getting more complex. There's a off the top of the head list of the sorts of issues that we're facing. Australia at the moment, where I am, is going through a huge public discussion about violence against women and girls. We've had strategies in place for the last 10 years that have been pretty much unidimensional and unisectoral and not working. So we're going through that discussion, and that happens in different ways in different jurisdictions around the world. Often we see the issues through one set of paradigms and one perspective. We see them either as crime or a public health problem. Now, I'm going to generalize wildly here. I'm a public health person, and I've been working in this area for 15, 20 years. And it's been a lack of recognition that there is a need to see issues as public health issues, once they have been criminalized, is a very difficult barrier to overcome on the public health in the public health world, from the public health perspective. Once something has been criminalized, we tend to see as a society that reactions to that, the responses to that issue, fall within the criminal justice sector and they leave the public health sector. The fact that we divide a lot of these sorts of issues up into being either a public health or a law enforcement responsibility means that we get it wrong. We get it wrong regularly and often. the issues are neither the one nor the other. And I'd never tire of pointing out that there is actually no such thing as crime until we define it as such. And the process of defining something as a crime, as well as removing it from consideration as a public health issue often, also of necessity carries with it a journey into the criminal justice system. And there is plenty of evidence, and I don't think I need to demonstrate it over again, that the intertwining of the criminal justice system and health issues, there are many health issues that make it more likely that you will end up in the criminal justice system. Being in the criminal justice system is bad for your health in lots of different ways. Criminalisation of issues that really should be dealt with as either public health issues or often not as issues at all. Many things around the world are criminalised that should just be treated as part of normal life. Criminalisation of these issues doesn't solve the health issue, and it breeds further criminalisation, further involvement with the criminal justice system. And again, I don't think I need to demonstrate that. The largest risk factor in every jurisdiction around the world for your chances of being incarcerated are having been incarcerated before. Incarceration breeds crime, teaches crime, carries all sorts of stigma and shame, and cuts off other life opportunities all through and down through the generations. It spreads, the effects spread, not just for the individual to his or her family, and then down through the generations. So single sector approaches, we have plenty of evidence now, don't work for these complex issues. Yeah, oh, okay, I can do that. Again, the exciting work that's been going on over the last decade, looking at the common determinants, underlying determinants of entry either into criminal justice or into the health system, with the recognition of the role of adverse childhood experiences and adverse community environments. I'm showing here a slide that was put together by Wendy Ellis at George Washington University. And I think it's a start. Justin can talk more about this, and this is a starting point that has been elaborated on quite a lot. But these childhood experiences and community environments underlie both entry to criminal justice through the commission of what we have characterised as crime or classify as crimes, and into various sorts of aspects of the health system, be it mental health, drug and alcohol, or other issues such as acquired brain injury. The entry into one or the other system with these underlying determinants is very much determined by socioeconomic factors such as race and class. We get it wrong all the time. We continue to increase our prison population globally. We incarcerate people for reasons that, again, I'm probably telling you things that you know very well. The easiest way for a lot of people in America to get access to mental health treatment is to go to prison. The public health infrastructure doesn't meet the needs of a lot of the people who need it, and what happens instead is they end up in the criminal justice sector. I'm working a lot in and have been working a lot in the global south, and it's become very clear to me that it's a rule that where there is an inadequate public health infrastructure, and we face one of these complex issues, there's always a strong criminal justice sector, even where there's a weak public health sector. And therefore, by default, a lot of these issues go into the criminal justice sector. What they should be doing is driving investment in public health, instead of which they go into the criminal justice system, and that strengthens the reliance on the criminal justice system. Mental health, drug and alcohol, acquired brain injury, all sorts of issues that should be dealt with other than in the criminal justice system end up in the criminal justice system. And again, examples of this abound, and we're all very familiar with what's going on in the States because of the magnifying effect of social media and other aspects. But this is a universal phenomenon. It's not so bad in some countries. The costs of this misclassification, this misalignment of how we respond to these issues are enormous. I didn't think it was the place here to go into actual detail about this, but and again, I'm sure that simply indicating it, you know exactly what I'm talking about. The costs of incarcerating people for issues that should be dealt with in the public health sector are enormous and ongoing and lasting. So our challenge is recognising that involvement with the criminal justice industry is detrimental to health. It's a major determinant of poor health over the life course, and it's systematically inequitably distributed. Police and prosecutors are the gatekeepers. in most societies, police, and in many, many cases, police actions have a huge impact on health and safety, either detrimental or positive. And there's a challenge. How do we get public health and law enforcement sectors to work together? There are lots of barriers to that joint approach. One of the barriers is a lack of recognition on the part of both sectors of the importance of the other sector. Public health prides itself on being the most multi-sectoral of all disciplines. And I've just illustrated it there with one list. If you go to any public health website, including WHO, but all the schools of public health and the public health associations, they'll all have a list of all the specialties, all the professions and disciplines and specialties involved in the public health exercise. And it's endless. Nutritionists and town planners, everyone has their role in achieving optimum public health, except police. Police are never there. And I can say that almost categorically because I've looked at a lot of those lists. Police never figure. There's a blind spot somewhere within public health about the role of police. It's mirrored on the other side with a lack of recognition on the part of a lot of police agencies of their role in achieving public health goals. And my good friend Scott Burris, I think, had the best, and I'm very jealous of the title of his article, specifically in relation to the involvement of police, engagement of police in the HIV response, the mysterious case of the missing cop. Why do we not see the role of police in public health? We don't teach it. It's the role of police in public health is in, I was going to say in no Master of Public Health courses. I think Scotland is probably different from that now, but it's starting to develop. But even the first-rate schools of public health do not teach about the role of police and other law enforcement in achieving public health goals. There are lots of alternatives, and people are experimenting and exploring alternatives to reliance on police, reliance on criminalisation to deal with these complex issues all around the world. Netherlands, the famous Top 600 project, where at the end of each year, the police look at the 600 people who've used most police resources in the preceding year and then throw everything at them, be it housing, employment, drug counselling, mental health, whatever it is they need to get them out of the criminal justice system. And it works. The violence reduction units in the United Kingdom, and again, I'll leave it to Justin or Helen to talk about those, but taking a public health approach to policing issues that really should be public health. And England has been a leader in this area, and Helen and Justin are the two who pulled this together. The UK consensus, which I love using this slide when I'm talking to people about the need for law enforcement and public health together, because I think I'm right in saying that those are the logos of every national police, health and welfare agency in England. And the statement that just having all those logos on the one page carries is the important statement. We've got to work together. I don't have time, I could go through a whole range of case studies and examples of innovative programs. We've been systematically looking for these programs around the world over the last few years, and I'll show you later on some other examples. But here's one example: law enforcement assisted diversion, which arose out of Seattle, and it's just one version of a diversion program that people are exploring and using in many other parts of the world in different shapes. This has now been taken to the global south, to South Africa and Vietnam, and demonstrated to work in different cultural settings as well as the first world, as well as the global north. So in the Global Law Enforcement Public Health Association, one of the discussions we've had over the years has been about language. How do we find a common language between the two sectors? On the surface, with a lot of issues, it would seem that they have different objectives, different goals, different ways of thinking about issues. Illicit drug use is a classic example where the phenomenon is characterised very differently in the different sectors. What we've arrived at is a Canadian formulation that what we're both working towards, both sectors are working towards, is optimum community safety and well-being. And it has to be recognised that the law enforcement sector does a lot of things other than enforcing law. So if the law enforcement sector includes police, public prosecutors, coroners, magistrates, and so on, they do a lot of things other. In fact, I think the surveys are fairly consistent around the world that police spend somewhere of the order of 15 to 25% of their time dealing with crime. Most of their time is is spent dealing with services to the community. So law enforcement is critical to the treatment of public health. You don't have to look at a whole range of examples to immediately grasp that. One immediate example, which Jonathan's area, is road trauma. How do you decrease the public health burden of road trauma without seeing the critical role of police? But as you look at it, it goes on into a whole range of different. I find it hard these days. When we first started our conference in 2012, I thought we'd be dealing with 6 or 7 issues, major issues: mental health crisis, domestic violence, pandemic responses, and so on. As the conference has gone on and as GLEFA has grown, the range of issues that we deal with now has grown to a huge list of issues. I find it very difficult now to think of a major public health issue in which the role of police is not at least important, if not critical. We need to build what has been started in different jurisdictions. As I said, it's probably most developed. The thinking is most developed in the UK, and different jurisdictions are looking at these. How do we bring the different sectors and get a joined up response together in different ways? The Global Law Enforcement Public Health Association, which I'll talk about in a minute, is trying to, a bit later on rather, is trying to help promote that bringing together in research, in policy making, in demonstrating innovative programs and the success of innovative programs so that people can be inspired by them and share them, and generally to advance knowledge and understanding in the field. This is a major effort, I think, to address health equity. The health states are hugely inequitably distributed. And one of the major reasons for that is the classification of issues according to socioeconomic status into criminality or health. The Law Enforcement Public Health Partnership is a way of addressing that and keeping people out of the criminal justice system, and in the longer term, bringing about preventing much ill health and premature mortality and redressing that inequity. Thank you.
Thank you, Nick, for setting the scene excellently on the importance of bringing policing and public health together rather than being siloed working. We'll now move over to Jonathan, who's going to talk about some areas where policing and law enforcement can deliver public health interventions. You're on mute, Jonathan.
I'm on mute. Here I am reminding everyone about functions of Zoom, and I'm the worst offender. Can everyone see my my slides? Okay.
Yes, it's up.
Excellent. Okay, so I wanted to, as Nick introduced, one of the main areas of my work in WHO in the European region is on road safety, and that's sort of for a public health organization working on road safety. It often leads to observations such as this title, which I'll get to that elephant in the room in a moment. I wanted to highlight for those in our audience who aren't familiar with the issue of road safety and road trauma. The staggering realization is that someone dies on our world's roads every 26 seconds, and that is a statistic that I think simultaneously stuns and horrifies people who hear it. But you know, despite the importance of numbers in public health issues and good information sources for public health issues, we can never ever forget the human face behind those numbers. So when we think of road trauma and road safety, we have to remember that we are not dealing with just empty statistics. We are working very closely with families of those who have lost loved ones, and so all of our work in road safety is dedicated to the legacy of families such as those of Tara from Malta, Yannick from the Netherlands, Darren from Ireland, and Tamir from Kyrgyzstan, just to name a few of those who have tragically lost their lives. Importantly, road trauma is also a leading cause of death for those in police service. In the United States, for example, more police die. The police deaths in the line of duty are second. Police deaths due to road trauma in the line of duty are only second to that of firearms. So this is an important occupational risk for policing services as well. So coming back to that point that I made right at the beginning about why would a public health agency, why would the World Health Organization be interested in road safety and road policing? Well, the reality is that with the burden of death, as well as the very astronomical burden of health system burden, road safety is a public health priority. It might be, and as it is in many countries, outside of the public health jurisdiction, but that doesn't mean that we don't have the ability to see this as a public health problem. And as Nick mentioned, public health problems are intersectorally and multi-sectorally tackled. The World Health Organization, for those of you who don't know, is actually appointed by the UN General Assembly as the lead agency for road safety within the UN system. We have over the last decade and more been working towards achieving the SDG 3.6 target of a 50% reduction in deaths and serious injuries, and this continues towards 2030 in the second decade of action for road safety. Our approach here is one of safe systems, which is very akin to a public health approach. In that we recognize that that humans are both fallible and fragile, and so we adopt a series of simultaneous interventions that are aimed to achieve safer road users, utilizing safer infrastructure in safer vehicles, traveling at safer speed, as a way of accommodating the consequences of human error. Oops, too far. We have just for information, for those who want more information, we do have a very significant category of publications on different aspects of road safety, including an upcoming publication on road policing practices. One of the latest publications for your information is the 2023 Global Status Report on road safety, which is a globally monitoring tool for measuring progress in road safety. So here in the region, in the European region, we are actually considered to be one of the safest regions of any WHO region. And since the turn of this millennium, we've actually achieved a reduction of almost 50%. In the number of deaths occurring in our roads, which is a significant achievement considering that in some regions they are yet to see any reduction whatsoever. But related to what Nick was saying about equity, we have to note that across the 53 countries of the region, road trauma has a 10-fold difference in mortality across the countries of the region. 10 times more likely to die on the roads in countries that are less advanced in their road safety practices and objectives than those who have been those countries that have been implementing these kind of evidence-based interventions for longer. And importantly, despite the progress, road trauma is still the leading cause of death in our region for all countries, high-income countries, low-income countries, and middle-income countries for those aged 5 to 29 years of age. This is an unfinished agenda. And importantly, we need to, when we start to think about how this relates to road policing, we need to look at road trauma relative to some other important policing priorities, such as homicide, for example. When we look at these sort of examples of how road trauma, how the mortality rate for road trauma relates to the issue of homicide and fatal interpersonal violence, for example, which in many contexts is a very preeminent police priority. The numbers are very surprising. The risk of dying on the roads in all of these regional countries is 2.5 times higher than it is the risk of being a victim of violent crime. And so this is an important consideration when police agencies are determining priorities for, determining their relative priorities across competing demands. You know, even when we look in more conflict-prone scenarios, such as these countries that are currently where the United Nations has peacekeeping presence, you can see that road trauma, even in these contexts, road trauma is largely almost universally is a higher burden on the population than the issue of violent crime. And so when we look at how road policing as a discipline has transitioned over the years, it has the emergence of road policing as a sort of a topic has come about from transitions from this notion of managing traffic to essentially policing road users, and now more recently the objective is the prevention of road crime, where in addition to enforcing road safety legislation, the objective is actually to deter and prevent criminal utilization of our roadways. For the last few moments of this presentation, I just wanted to highlight a couple of examples in road safety spaces where stringent enforcement of legislation has been particularly critical in saving lives on our roads. The first example here is from the Australian state of Victoria, where I'm originally from. And it highlights, this is a photo that shows how police in Victoria, and in fact all Australian states, enforce drink drive prevention through random breath testing, highly intensive random breath testing. And in this example, between 2010 and 2014, this intensive enforcement and the creation of this general deterrence basically reduced the involvement of alcohol in road trauma, reduced alcohol-associated deaths by more than 45%, a very significant reduction. Another example from the country of France, where they in 2018 reduced their speed limits. Whoops, wrong way. Sorry, reduced their speed limits on the majority of their road network from 90 to 80 kilometers per hour. And this policy, coupled with intensive enforcement, actually saved more than 349 lives in only the space of 20 months. And this was also simultaneously at a time of significant protest to this policy. And so it's important to note that much of the policing resources, such as the speed cameras, were vandalized at this time, and yet still the enforcement managed to not only have a significant impact on deaths and serious injuries, but also reduced the cost of road trauma by more than 700 million euros over this time. The final example here is from Vietnam, where I was working for more than 6 years on the implementation of motorcycle helmets. And this is an example of how the withdrawal of enforcement actually leads to the disappearance of the kind of road user behaviors that you want to see. So in this example, there was the legislation was passed, but for various reasons, it became once it was adopted, it became clear that it could not be enforced. And as you can see, that lack of enforcement led to an almost immediate reduction in wearing of helmets. And it wasn't until all of those enforcement challenges were resolved that helmet wearing started to return. And just to, as one final note, I wanted to highlight just in more detail the fact that WHO is finalizing, in conjunction with the United Nations Policing Agency in New York, a new publication on best practices for road policing and how enforcement as a strategy is crucial to achieving the kind of road safety and public health outcomes that we wish to see. I'll stop there. Thank you very much.
Thank you, Jonathan, for those tangible and really clearly explained examples there. Before we move on to our next speakers, I'll just remind everyone of the Q&A function. If people have any questions at any point, if they want to submit those using the Q&A function, we'll look to try and answer those at the end of the session. But now we'll move over to Helen Christmas and Justin Srivastava, who are talking about some of the examples of policing and public health working together in the UK. Helen Christmas is a public health consultant at Hull City Council and public health advisor for Humberside Violence Prevention Partnership, and has previously worked at Public Health England on public health and policing, whilst Justin is superintendent at Lancashire Constabulary and the strategic policy and workforce development lead for the Lancashire Violence Reduction Network. So thank you very much, and over to you.
Brilliant, thank you, Sean. I'm just going to share my presentation. If you bear with me for a moment. Can you see that now?
Yep, that's up. If you can just go to presenter mode.
Are we there?
Not just yet. It's yes, there we go. Perfect.
Great.
Thanks.
That's brilliant. Thank you. Morning or afternoon or evening, everybody. Really good to have this opportunity to talk with you. I'm sorry I can't see you all. It's really hard delivering a presentation when you can't see the people. So I'm sorry I can't see you. Please do use the chat if anything doesn't make sense, or I lapse into acronyms, or we're talking about things that don't make sense in your context. So please do use the chat, and Sean will interrupt me if needs be. So Sean's introduced me. I'm Helen Christmas. I'm a public health consultant in Hull in England, and work also within the Humberside Violence Prevention Partnership. Justin, do you want to introduce yourself now?
Yeah, morning, afternoon, evening, good night for some perhaps. My name is Justin Srivastava. I'm a serving police superintendent in Lancashire, which is the north of England. I also work on the Lancashire Violence Reduction Network, which we'll talk about in a sec. And for the since 2016, I've been working on the National Police and Health Consensus work, as well as being part of GLEPA.
Brilliant, thank you. So what we're going to talk about to start with is what we mean by public health approaches in policing, and some work that we did a few years back now to really try and articulate that. So I'm going to talk about that and what the 5 key areas are in our perspective on what a public health approach looks like. Justin will then talk about the serious violence duty, which we have in England and Wales, which sets out in legislation our responsibilities to prevent and tackle serious violence. And he'll talk about the Lancashire Violence Reduction Unit, which is one of the units set up to deliver on that serious violence duty. And then finish off briefly with some of the resources that we have from our National College of Policing for England and Wales. So that's the plan, and Sean will interrupt if we're overrunning with time, which does happen often, it has to be said. So public health approaches in policing. This is a piece of work that we did. It was published in 2018, and the backdrop to it is that we've been working together nationally between policing, public health, voluntary sector, other health organisations for a little while, and had developed a consensus agreement between policing and health around our common goals. And we often met in our working group and talked airily about our public health approach. And one day someone really challenged and said, what do you actually mean by that? And having heard that question a couple of times, we thought, actually, let's sit down and try and really articulate that. What does it mean to us when we're talking about public health approaches in policing? So we had all sorts of different brains on this, from policing, public health, voluntary sector and other organisations, and came up with this discussion paper and those 5 key elements that we think form a public health approach, whether you're looking at policing or anything else for that matter, but this document was particularly focused on policing. So that's starting from a population level, looking at the causes of the causes, prevention, being true to the data and the evidence base, and working in partnership. So we'll talk through each of those, not necessarily in that order. So the first one is always that a public health approach starts at a population level rather than at an individual level. And we have a saying locally, you can't see the wood for the trees. And public health is the bit, or a public health approach is the bit where we look at the whole wood. So a response police officer or an emergency department consultant will look at the individual human being in front of them. Their duty is to that tree, if you like, to that individual. Whereas a public health approach also looks at the whole community and sees the different patterns, sees the different needs, which bits are thriving, which bits aren't, which bits are growing well, which bits are stretching out a bit. And when you put those together and you've got that big worldview perspective where you can see the whole wood and you can see the needs of those individual trees or individual humans, that leads to better outcomes and a better quality delivery of services for people because we meet their needs better. So that population focus doesn't replace that dedication to individuals or that responsive work with individuals, but it sits alongside it and underpins it so that we can see what's going on and the big picture at the same time. So that's what we mean when we talk about a population focus. There's various ways of looking at this. One of them is, we call it shifting the curve. And it's that concept, that idea that sometimes doing a little bit of change across the whole population will have really big outcomes. And usually we target our resources at the people with the greatest need. So there's a classic example of this in healthcare, whereas if you reduce the blood pressure of a whole population by a little bit, you prevent more strokes than if you'd reduced the blood pressure of the people most at risk by a lot and not done anything with the rest of the population. And Jonathan actually just gave us a really good example from France of reducing speed limits. Reduce the speed limit by a little bit for everybody on key roads, and you have a really significant reduction in deaths from road traffic accidents or road traffic collisions on those roads. So that's not to say we wouldn't ever want to focus resources on those with the greatest need at all, but it's stopping to think, actually, is there a different way? Could we have an impact, a really significant impact, by doing a tiny bit of change for a lot of people at that big population level? So it's always something to consider when you've got some resource, you've got a problem you're trying to address, the different ways of looking at it. Inequalities is really significant. We know the evidence tells us the more unequal a society is, the worse its social outcomes. That summarises an awful lot of research very, very quickly. But there's a book called The Spirit Level by Kate Pickett and Richard Wilson, which sets it out in much more detail if you ever want to look into that. And so it's really important that whatever we're looking at in terms of intervention, whatever outcomes we're trying to achieve, we're thinking about, actually, does that work for everyone? Have we missed some communities there? Are there some people that we're not actually meeting their needs, or who can't access this wonderful thing we've just set up because, for example, we've assumed that they've got internet access, and the poorer you are, the less likely you are to have that, things like that. So inequality is really key all the way through what we're talking about in terms of a public health approach, and making sure that we're not missing out some parts of the population. Talk also here about proportionate universalism, that idea again that if you only focus on a few people, you don't have that big impact across the whole population. So the second cog, if you like, in our public health approach toolkit is looking at prevention. And prevention is something that is absolutely key to the mission of policing and absolutely key to public health and many other sectors besides. And we tend to look in public health at primary, secondary, and tertiary prevention. And actually, when we looked into this, we found work on policing and criminal justice dating back decades that also had that primary, secondary, and tertiary breakdown of prevention. Primary prevention, in essence, is preventing the problem occurring in the first place. Secondary is getting in there really early when a problem's just beginning to emerge and preventing it becoming established, or we quite often refer to that as early intervention. And tertiary prevention is when you've got an ongoing issue or an illness or a problem in a community, making sure that it's well managed so that you're avoiding crises, minimising the harmful consequences of it. And on the left there, you've got that pyramid, where in an ideal world, we'd have lots of primary prevention, a little bit of secondary, and not need much tertiary prevention at all. But in reality, for most of us, that pyramid is upside down, and we spend most of our resource and most of our energy on tertiary prevention, on crisis management, on reacting to existing issues, and much less getting further upstream and preventing those becoming problematic in the first place. And this, I don't know if you'll be able to read this, it's really small, but these are a list of examples of primary, secondary, and tertiary prevention interventions, mostly from Lancashire. It was interesting, Justin and I were talking about this list yesterday or the day before, and really started to disagree on some different examples of what would fit in primary, what would fit in secondary. So again, and having reflected on that, I think we can get really hung up with what the exact definitions are and where the boundaries are. But the key message is, where's the balance between that primary, secondary, and tertiary in your system? Are we doing more to prevent in the first place than we are to respond in a crisis? And the other thing that's, I think, really important in this is when you're looking at a family context, actually, what might be tertiary prevention for a parent or a carer might well be primary prevention for a child or a baby. So it's really important to see that cycle as well, and that intergenerational cycle, and to see wider on what we might be doing. Primary prevention is obviously harder because it's really difficult to measure what doesn't happen. And it's always a harder argument to make in term when budgets are limited and there's pressure on them. But we do know that it's far more cost effective in almost every measure than waiting for things to get to a crisis point and intervening later. And I guess the other key point around this is that this isn't all for policing to do. This is about partnerships across systems and different agencies doing what they're best at. But just because it isn't necessarily for police to do doesn't mean that police might not want to be influencing that. So in the area where I work, it's a city called Hull in England, which has really high levels of social deprivation and poverty, some of the highest in the country. And domestic abuse is arguably the biggest issue that we have in our city. And so one of the key things, we're doing all sorts of work around what we call our first 1001 days program. So conception to age 2, really, really tiny ones, babies before they're even born and then before their second birthday, and working with families around the relationship between parent and baby and making sure that that's really healthy and that we get the best possible brain development in those very, very, very early months of a child's life. And our police aren't doing that, but they really support us with seeing the importance of that and support us when we're looking to make the argument for funding for that. Because if we can get it right then they will see far fewer of those families later down the line in domestic abuse circumstances. So just because it's not for everyone to do doesn't mean we're not all interested in what each other's doing across our system and influencing, because we've got those common aims and those common goals and are able to work together to achieve them. So the next cog in our toolkit is around the data, the evidence base, epidemiology. Quite a lot in one here. We were trying not to have too many cogs, and we piled a lot into this one. When we first started presenting this and we were talking about epidemiology, people didn't know what it meant. But since COVID, everybody knows what epidemiology is. And that's a study of patterns in a population and the risk and protective factors. And we can apply that to violence as well. We can apply that to other outcomes that we're looking to achieve or reduce. And it's back to that big picture at the beginning. What's going on across our population, and how would we prevent whatever it is that we're trying to prevent at the time? Public health approaches have a really, really strong commitment to research and evidence base, both to using what's out there and to growing it. And that we're certainly seeing that in England and Wales, and Scotland as well, across the violence prevention world, that real commitment to what is the research that's out there, how do we use that effectively, and make sure that we're using all the learning that's already been out there to choose the best interventions in the right context. And again, data and information sharing is both a barrier and an enabler, something there's a lot of work going on around in that serious violence context for us at the moment, right from that sharing of individual level data across a partnership, right up to that big picture anonymized population level data. Just an example, something we have here called the Youth Endowment Fund, which is quite really significantly funded by government to look at the evidence base around prevention of youth violence. And what they've set out to do is a phenomenal aim, and a really fantastic aim is to gather and review all the research evidence around youth violence and the risk and protective factors. And then to rate that and put it in a toolkit. And some of the funding that we receive through that serious violence route is tied to you must spend a certain proportion of it on interventions that are rated as high impact and good evidence quality by the Youth Endowment Fund. And this chart just sets out some of those. There's just a bit of a caveat though. This is a really blunt tool. So it's a fantastic aim, but a very, very blunt tool, because when something hasn't attracted research funding, it won't have clear evidence of whether it's effective or not. And therefore, this approach means that we can't then use that and then build the evidence base around it, because we're directed to do the stuff that's already got good evidence. And also, when you present it in a simplified way like this, you lose some of the nuance around what was the outcome that they were looking to achieve in the first place, what they were measuring. So where it says, for example, no effect for street lighting, that doesn't mean street lighting has no effect. It means that in this specific context, in the studies that were done to see if it reduced youth violence, it didn't reduce youth violence. That does not mean that street lighting isn't hugely important in terms of violence against women and girls agenda, for example, or in making people feel safe in their community, or in preventing accidents. So just have to be really careful in how it's used, but it's a fantastic effort to try and make that evidence base live and usable, and make sure that we're doing the best possible evidence interventions that we can. I think the other thing just to look at is what doesn't work, and there's evidence that things like boot camps and prison awareness programs are actually harmful, so they do the opposite of what people were looking at. And in this top category here, where you've got really high impact on reduction in violence amongst young people, many of those approaches are multi-agency, many of those are holistic. It's not all of them. It's not to say there aren't things with less good quality evidence around, but it's just interesting how that fits into what we're talking about around that multi-agency approach, and using everybody's skills to the best effect. Next one then, I think we're on number 4, partnerships, communities, system leadership. So everything we've talked about this morning, right from Nick talking about those common goals across public health and criminal justice, is about working together across a system, whatever that system looks like for you. Trusted relationships are absolutely key, and that you can't legislate for that. You have to build that, and you have to work hard. And often you work really hard and develop those relationships, and then the police have a reorganisation and move everyone on 6 months later, and you start again. But we always start again and rebuild those relationships, because together we can achieve far more than we would on our own. I've talked already about not all for the police to do. And when we first started talking about this, that was often people's fear, and often the pushback that we got was, you're asking police to do health jobs, and that isn't the case at all. This is looking at everybody's skills and influencing across a partnership to make sure that we're bringing together what everyone can offer. So it's not asking police to do health job at all. It's asking us to understand each other's strengths better. And make use of each other's strengths and approaches where they're useful. Place-based leadership, that phrase means lots of different things to lots of different people. Place has a whole new meaning now in England from an NHS perspective. But the idea that this is about leadership, this is about leading across your system or across your place, to have that absolute focus on those common goals around reducing entry into the criminal justice system and improving quality of life for people. And that last point around involving communities is key, really underpins the whole thing. It shouldn't be the bottom bullet point on a slide, really. And we call this lots of different things. That might be lived experience, it might be co-production, but that idea that if we don't have the voice and the influence and the input and the learning from people who have real experience of what we're talking about, we will miss the point often. An example from Hull of this is we have a group that meets regularly about reducing harm to sex workers that has police, it has public health, it has housing, adult social care, children's social care on there, but crucially is led by some people with lived experience of street sex work and homelessness and drug addiction who now work as advocates for women in that position. And together, we've been able to have much more impact on understanding the needs of our street sex workers, being able to support them, being able to avoid criminalisation wherever that's appropriate, and building those trusted relationships so that we've got people who trust our local police set up who are advocating for sex workers. And that's taken us years, but it's a really powerful piece of work. So that's it's just a small example, but if we don't involve our communities, we won't really understand what's going on the ground. So the final cog in our toolkit is around the causes of the causes, and usually we talk about this a bit earlier on, but I've left it to the end here because it really introduces what Justin's going to go on and talk about. And a really key aspect of a public health approach is not just looking at what's presenting in front of you, but thinking why, what's behind that, what's the cause of that, and what caused that cause and caused that cause and caused that cause. How far back can we go in understanding why an issue is happening or a behaviour is being presented to us? And that's the impact of life circumstances. I've talked before about looking at population level and that not being deterministic for individuals. So we know that at population level, for example, 50% of smokers will die from a smoking-related disease. That doesn't mean that every smoker will die from a smoking-related disease. It means we know it's quite a significant risk factor for them, and we'd know to consider that, but it doesn't mean they will. And it's the same with all of this about what we call the determinants of health, social determinants of health, or we'll go on to talk about in terms of adverse childhood experiences. We know that adverse childhood experiences or adverse community situations really increase the risk of all sorts of poor outcomes for people. But that doesn't mean that every individual who's had a rough childhood will be involved in crime. And we need to be really clear that we're not overlaying evidence inappropriately to individuals. But all of these things here on this diagram, I don't know how much you can read of it, but things like social and community networks about living conditions, water and sanitation, education, all have a really significant impact on your risk of being involved in violence or being involved in crime or being a victim. And they're all really important if we're going to prevent all of those things. So I'm going to hand over now to Justin, who's going to talk more about adverse childhood experiences and then lead that on into trauma-informed practice.
Thank you, Helen. What the next section I want to talk about, I wish I'd known 30 years ago, because it would have made a difference to how I was a police officer 30 years ago. And Helen talked there about the causes of the causes. And as a police officer, we see a lot of community members that are dealing with drugs, alcohol, mental health issues. But actually, what we need to do is look at those underlying causes of the causes, because when we do, that takes the social determinants, that takes the health inequalities, but it nearly always takes us to trauma, and it nearly always takes us to poverty in some shape or form. So therefore, there's a real link between trauma-informed practice and policing. And when you look back to how policing started, certainly in England and Wales, it started with the Pelion Principles. And one of the key Pelion Principles was the prevention of crime and disorder. And therefore, part of prevention is part trauma-informed practice. And in my Lancashire role, we have trained 11,500 frontline practitioners in trauma-informed practice. And one of the key themes that comes from our police officers over and over again is, I wish I'd known more about neurobiology. I wish I'd understood more about how the brain science works, because I would definitely have treated people differently. And actually, sometimes we're seeing intergenerational effects where we're now dealing with grandchildren, we're originally dealing with grandparents. So trauma-informed practice is really, really important to policing in the UK. This slide here talks about, in a 7-minute briefing, and as you know, we like to use 7-minute briefings about what trauma-informed practice actually is. Skills such as compassion, empathy, kindness are key parts of the caring nature of being a police officer. But when you look at those principles there, empowerment, voice and choice, trust, collaboration, safety, peer support, cultural, historical and gender issues, these are all key parts of delivering trauma-informed practice across all of policing, but with our partner agencies as well. And therefore, certainly here in Lancashire and other areas of the UK, we're training our police officers in these exact issues, because we assumed that they were part of the original curriculum for new recruits, and they weren't. So we're starting to build that in order to train both our new officers and our existing officers and staff around trauma-informed practice. Thank you, Ken. It wouldn't be a presentation if we didn't have a slide on Maslow in some shape or form. But the reason that I always put this slide on is the bottom bit, because the bottom bit around physiological and safety needs includes trauma and psychological safety. So in order to help people self-actualize, i.e. become the person they want to be or they most want to be, we have to deal with the basics first. And that includes dealing with trauma, adverse childhood experiences, and perhaps most importantly, shame and shame-sensitive practice. Because in order to deal with trauma, we have to address the issue of shame first and foremost. And for those of you that are interested in shame-sensitive practice, there's an awful lot of work coming from an academic called Luna Dolasai, looking at how we deal with shame first and foremost, and then we can deal with trauma afterwards, because by dealing with shame, it helps us deal with the trauma. Nick mentioned the work of Wendy Ellis, and this is really important because on the left-hand side there, you can see the 10 adverse childhood experiences, and there's an awful lot of people on this call who are absolute experts and are involved in the ACEs work and have been for a number of years. But actually, when we started looking at adverse childhood experiences, 10 of them there, awful lot of them surrounding violence. But every day, our frontline practitioners are dealing with issues that aren't necessarily adverse childhood experiences. And you can see them on the right-hand side there, the traumas that we will deal with every day: bullying, being victim of sexism, racism, homophobia, separation, being in care, and so on and so forth. So I think it's really important that we use the ACEs work, but actually talk in a trauma-informed way and talk in a much wider way around trauma, because that's what our communities are dealing with every day, and therefore our frontline practitioners are dealing with every day, both in the communities, but also for themselves as well. Because we know that 1 in 4 members of the community in the UK have had significant trauma in their life. That means 1 in 4 of our frontline practitioners are in exactly the same boat. Down at the bottom there, there's a whole piece on adverse community environments. And again, this is really important. I love this route analogy, because unless the community environment is right, it doesn't help us deal with the ACEs and the trauma that are with our individual community members. And you can see there, when we talk about adverse community environments, you've got things like poor housing, systemic racism, lack of access to educational opportunities, long-term unemployment, unhealthy products, and so on and so forth. In order to change our view and our community experience of ACEs and trauma, we need to turn those issues on their head. So straight away, as an example, you see poor housing quality and affordability. You'd want good housing that's affordable and of good quality from our communities. So turning those on their head actually gives us the strong root, the strong foundation in order to deal with adverse childhood experiences and trauma. And therefore, there's a real need to bring our communities together around addressing trauma. It's not for one individual agency to do, it's for communities as a whole to do. Thank you. But here's the thing, and Helen touched on this earlier on. This is multi-agency. The one good thing, or one of the great things that the ACEs work gave us was a common narrative. So by addressing ACEs, on the one hand, we're talking there about heroin and crack cocaine use and incarceration, but we're also talking about smoking or early sex or unintended teen pregnancy and so on. And there's a real common narrative there that goes across the breadth of all agencies to come together around addressing adverse childhood experiences and trauma. There's a business case here, a cost benefit as well, because the earlier we deal with things, the less they cost the system. And therefore, they are a benefit to our tax-paying communities and communities as a whole. So the ACEs work has given us a real strong common narrative, which is why a lot of police services in the UK are using the ACEs to create that common narrative. Well, the thing is here that as system leaders, we need to be able to learn, to be able to lead beyond our own authority. We cannot do this alone. So our future system leaders need to be able to work with other partnership system leaders at both the place level and the strategic level to start to address these issues together. Because if we don't, and we stick and remain in silos, we won't actually have the biggest impact in our communities, and therefore we won't prevent stuff, and therefore we won't be doing right by our communities across the UK and globally. Thank you. Okay, this slide is about the trauma-informed journey, and this one I always like to put the shocker in. I will challenge anybody to say they're truly trauma-informed, or any organisation to say they're truly trauma-informed. And the reason for that is, in order to be truly trauma-informed, which is phase 4 at the bottom of the journey there, you have to change everything. Your policies, your procedures, your culture, your estate, how you recruit your people, how you retain people, how you progress your people, and so on to be truly trauma-informed, to take that overarching strategic approach. So for most of us, ourselves included, it's a journey. You start becoming by being trauma aware. So you're actually doing that today. You're aware, you've heard something about trauma, you want to know more about it. We move into being trauma sensitive, which is actually, I want to learn more about it. So I've gone out and found some more. And then phase 3, where a lot of people are and a lot of organizations are, is I've learned about trauma, I understand it, I understand ACEs, but now I want to respond to it. I want to start doing some stuff in order to address it. And eventually you get to truly being trauma informed, which is I've done anything I possibly can in order to be trauma informed. The term trauma informed, though, has become a bit of a brand, so we all use it. But there is phases, as you can see there, that take you through that journey. Somebody did point out the other day that it should be a roundabout, and we have to keep going round in the circle. So I'll leave that to colleagues on the call to decide. I love this slide, and the reason I love it is a couple of years ago in Birmingham, we brought all 20 violence reductions units together, which I'll talk about more in a second too. But we had a visual artist with us, and the question we asked them all is, what is trauma-informed policing? What does it mean, and how do we do it? And the visual artist created this from a blank piece of paper. So for those of you that from a policing background, if you do all of this, then you'll be on that journey towards trauma-informed. But as you can see, there's an awful lot there. So actually, we use it, and we've developed an action plan and a development plan based around this. And in Lancashire, in every police station in Lancashire, we have one of these boards. We've blown it up. They're really big, and we use it to help get our staff, our police officers, our police staff, to have a look at it and just read it, because you can spend an hour reading all the bits of it. But actually, it's been really educational. It's been really helpful across the policing landscape in helping people to understand what trauma-informed policing is, and perhaps more importantly, what does trauma-informed policing do, and therefore start to engage in that cultural shift. Thank you. I won't dwell on this too long because it is all on in England and Wales, but I know that other countries have aspirations to do something similar. In 2023, England and Wales wanted to have a serious violence duty to bring together all the areas to set the standard around how we're going to address serious violence. And the reason is this: as you can see there, the stats are quite stark. In 2016 and 2021, over 100 children died from knife violence in England and Wales. Almost 500 children went to the emergency department after being stabbed, some as young as 7 or 8 years old. 1 in 7 teenagers is a victim of violence. 1 in 13 teenage girls sexually assaulted. 1 in 10 teenage girls are either witnesses or victims of violence. That comes from the Youth Endowment Fund, but it's stark. So there was a serious violence duty that was set up for every area of England and Wales, and Scotland have a violence reduction unit as well. And there are 20 violence reduction units in England and Wales. 23 areas don't have one at the moment, but they're all subject to this duty. And the bit that I want to zoom in on is the fact that they've put prevention into it, into statutory legislation, and it's the bit in red. In addition to tough law enforcement, we need to understand and address the factors that cause someone to commit violence in the first place, i.e. putting prevention straight into statutory legislation and making it a duty for every area in England and Wales to address prevention. Now, when you start looking at the causes of violence, you start to realise that those same causes also cause health inequalities, lung disease, heart disease, obesity, and so on. So actually, by addressing violence, you have a knock-on effect across the rest of the system. And that's put down here in this piece of legislation, and that we must identify the kinds of serious violence that occur in the area, the causes of those violence, and prepare and implement a strategy for preventing and reducing serious violence in the area. Every area has to have a prevention strategy. Every area has to know what drives serious violence in their local area. And in order to do that, how are they going to do it? Those words we heard earlier on, a public health approach, which I'm going to keep taking you backwards and forwards to those cogs that Helen talked about earlier on. So who's
Justin,
yep.
Apologies, just to let you know, 5 minutes.
5 minutes, no problem.
That's all right. Thank you.
Thank you, Sean. So on the left-hand side are the statutory partners that have to engage in the serious violence duty. And what you've got there is a plethora of really important agencies coming together to address serious violence together. And it's not just one agency's responsibility, it's all of those agencies together. Where it talks about health, it talks about something called our integrated care system or integrated care board. And that's where all the money comes from central government into our health partners to be distributed across health providers. So the money place is in England and Wales is where it's coming into. Thank you. There's also a data sharing duty, and the bit in red's the interesting bit. It's about sharing data at an individual level in order to support disruption and safeguarding decision making, or in other terms, prevention. Getting upstream, sharing individual level data to prevent a person becoming a victim of or an offender of violence, which is a significant shift in the data piece across the serious violence duty. Thank you. Okay, I want to bring this to life a little bit. So I'm going to talk a little bit about the Lancashire Violence Reduction Network, where I work. Next slide, please. Jump on. Thank you, Phil. Next one, thank you. Here on this slide, it's very busy. Can you just go back one slide, please? I'll just very quickly. Under the prevention piece there, you can see a whole thing around causes. I said to you, we know what drives violence in Lancashire. We know what drives violence in every single area in the UK. And in our case, education, employment, training, alcohol, substance misuse, poverty, and deprivation. Next slide, please. But actually, we've done a deeper dive, and you can see there, deprivation, exploitation, substance misuse, vulnerability, ACEs, poor parenting, absent parenting, neglect, and so on. And therefore, all of those aren't just for the police to do on their own. There's actually a need for partner agencies to work together. And if you came to my violence reduction unit, you'd see 35 partner agencies working with a common outcome. And here's the common outcomes: prevention, enforcement, evidence, and culture. So from a police officer's point of view, yes, prevention is really important to us. That is not an expense of enforcement. It's working together. You can prevent and enforce, and they can work closely together across the system landscape. Next slide, please. I mentioned cost benefit. For those of you that want to go onto the website, most of the violence reduction units have a cost benefit piece. In this case, we did a whole piece around what does violence cost the health system? £23.1 million a year. So therefore, prevent some of it, and there's a massive cost benefit to the system on a multi-agency basis. Finally, just a bit on the national landscape. We've done an awful lot of work following the consensus, which you can see there, which brought together the partner agencies, to start to look at what does good look like and how are police and health working together. How are we taking the public health approach? If you go on the College Policing website, you'll see a number of landscape reviews. We started the first in 2018. We've gone through into 2021, and the collaboration landscape, you can see there on that slide, it's a very busy one. But by all means, have a look in more detail on the College Policing website. You'll see more detail there. Well, next slide, please. Some of the initiatives that we've seen police officers and health partners and other agencies working on are here: suicide surveillance, use of naloxone to prevent drug deaths, trauma-informed community work, mental health safe havens, music therapy, and so on. This is police officers and police staff and our police community working with our multi-agency partners, adopting a public health approach in order to address those causes of the causes, those underlying issues that drive both crime, violence, and other social determinants and health inequalities, as we previously described. So, final thoughts and takeaway messages from Helen and I. Well, the first bit is, and I love this analogy, it's a salad, not a soup. We can't do it on our own. It has to be a partner agency approach. We've all got a common outcome, and that is, in the case of violence, preventing violence at the earliest stage possible. But we manage and keep our individual identities by joining the system up. If I was describing what a violence reduction unit does, it's that system join-up piece that's really, really, really important. Being able to lead beyond the own authority in your own organisation is really important as a system leader, and that's probably the future of police leadership, being able to step outside that police box and work across the system. So what does that need? Well, that needs police officers are very good in times of crisis, very good at the command and control type models, and we know them well, and they're globally accepted. But actually, there's also that social movement model, that move towards viral change and behavior change. And I talked earlier on around trauma-informed practice and how we need to change everything, including the culture. That means that we've got to have communities involved, we've got to have our practitioners involved, and we've got to have our system leaders all moving together, all making the same suggestions and going in the same direction in order to create that social movement and viral change. Public health approach is critical to that because data is a critical enabler. So not only do we need bold, innovative system leadership, but we have to have multi-agency data coming together to paint that picture to help us on our journey. And finally, it would not be a presentation from us if we didn't have the words of Desmond Tutu. There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. Colleagues, this is exactly what it's about. It's about upstream intervention at the earliest stage possible. And that's what the public health approach gives us across the partnership landscape.
Wonderful. Thank you very much both for that. And now we'll just move on to our final talk, back to Nick, who's going to talk to us about the Global Law Enforcement and Public Health Association. Over to you.
Thank you, Sean. We've had a quick journey around much of the world of law enforcement and public health, but there's a hell of a lot more going on around the world than we've talked about here tonight. I personally tried to get my School of Population Health interested in working with police to achieve public health goals through experience working in Asia on harm reduction and trying to get police engaged in the HIV response and really not doing very well. And Jonathan, I didn't actually know that I think I probably did know you were in Vietnam, but I remember having a conversation with a Deputy Minister for Public Security and him saying, my police are not social workers, my police catch criminals. And I was able to say, well, I was standing on the street of Hanoi yesterday watching your police enforce the new compulsory motorcycle helmet legislation. Your police do a lot more than catching criminals. So we held a conference in 2012 that we grandiosely called the first international conference on law enforcement and public health, just to see whether there was interest, and it's taken off since then. So that conference has now traveled around the world. It's been in Amsterdam in 2014, 2016, Toronto in 2018, a lovely conference in Edinburgh in 2019. And I'm saying that because I know that some of the organisers are on this call. COVID then got in the way, so we haven't had a proper international conference. We've had online events, and we're just gearing up again. So there was a regional European conference on law enforcement and public health last year in Sweden, and we're leading up to a regional African conference, regional African conference in Pretoria in December. The conferences, as I say, has taken off. Next year, we get back into the swing of annual international conferences in Ottawa, in Canada, and the year after it will be in Leeds, in the UK. They originally started having a conference every second year, but we went to every year an annual conference in 2019 because there is just so much going on in this area. How do I do this now? I want to share a different screen. I don't think I can. No, it's not that one. Sorry, I'm not very good at this. Anyway, out of the conference has grown the Global Law Enforcement Public Health Association. And the global, I'm trying to find I'll get rid of that one. Really, I'm not very good at this. Stop sharing that one. That's what I want to do. And then share. Sorry about this. I'm absolutely useless.
No problem.
Here we go. That's the one I want to share. So if I go into there and then I share that screen, it should show me the website of the Global Law Enforcement Public Health Association.
Yeah, that's showing.
And what I just wanted to say very quickly about that is a couple of things. One is that we cover a huge range of issues, as we've sort of touched on. We really scratched the surface in tonight's talks about the range of issues that we cover. And it's again a wild generalisation, but it's as a generalisation, most people I think in the law enforcement sector, particularly police, have had the experience of being generalists. Even if they're specialised in what they're currently doing, they've had the experience of being generalists. Public health tends to be different. People in public health tend to specialise, and one of the ways that we meet that need within the conference and the association is through special interest groups and through satellite meetings on particular topics. That's the range of active special interest groups at the moment that are working in GLEPA. Some are more active than others. The prosecutors' elected officials SIG is actually moribund at the moment. We're in the process of getting that up and going again. But a huge, as I say, huge range of issues. And one of the most active is neurodisability, neurodiversity in law enforcement public health. And that was a learning experience for me because I, on the surface, could not see, or did not immediately see what does neurodisability or neurodiversity have to do with policing. And I was educated by police who deal with people with Parkinson's disease, with the loss of affect and therefore interference with communication. And that opens up that whole realm of interference with communication and all the other causes. We've done over the last couple of years a series of projects looking at identifying innovative approaches and trying to bring them together. One of them is what we call the marketplace of ideas. This happens at the conference too. And the point about these is that there are plenty of people out there trying different things and learning lessons that can be shared, but there's no real platform for sharing those lessons except now our conference and through the Global Association. You can see here we scoured the world for innovative programs across a whole range of different public health issues and highlighted those in a series of webinars envisaging the future of public policing and public health. So drugs and harm reduction, deflection, diversion, mental health, violence prevention, a whole range of issues. And then the second stage of that, we looked at envisaging the future. What does the future look like in practical terms in what people are doing at the moment? And there's a series of reports from the webinars that came out of that exercise, looking at innovative programs. Now, this is something that we're trying to do more and more systematically, is to create a sharing platform where people can look at what's happening around the world. I was medical officer of health for a suburb in Melbourne at one stage, and we had a real problem with Indigenous public drinking and the conflict that was around that issue. And we tried all sorts of different things. Had I known that there were people in other parts of the world, in Vancouver and other places, who were working exactly the same problem and had some inspirational approaches that I could have learnt from, it would have made my job a lot easier, and we would have had a much better response. So trying to set up sharing mechanisms through the marketplace of ideas. I think that's about all I wanted to say about the conference and the association and special interest groups, and very happy to take questions. And if you want to go to either of those conferences in Pretoria or in Ottawa, please visit the website and register your interest, and we'll keep you updated with progress on the conference. Thank you.
Thank you, Nick, and thank you all for really great presentations. I think it was really clear from all of your talks the need for that partnership working, that it's not just something that any one sector or organization is able to do. And it's also something that's already happening. I know, Nick, you mentioned, only 20% of work done by policing is actually on crime. So it's clear that policing isn't only doing policing at the moment. So how do we make it work better by working in partnership with other agencies? Similarly, public health, how do we get public health to work with other agencies effectively? And I loved the salad not soup that Helen and Justin talked about there. I think to sort of bring everything together, I would like to just ask, on that partnership point of view, opening it up to all of you, what do you see as the barriers in bringing different organizations together, and how do we bring public health and policing together? And more importantly than the barriers, what are potential solutions, or what can people do to try and move that forward? So I'll open that up to anyone who wants to chip in there.
Thanks, John. I suppose I'll start from my personal experience. I think particularly government entities and policy entities, they are very much set up really to operate in silos rather than in partnerships. And sort of in the course of implementing work, that sort of element does often get strengthened rather than weakened. It's I think only through putting when entities start to put themselves out there and actually start to work in partnerships and see the benefits and see how we are stronger together, for example, and more effective together, that sort of mind shift is going to change. But we are also quite possessive of jurisdiction as entities as well, and so I think that's one of the important messages that needs to come out from dialogues such as this, that public health is not just a jurisdiction, but it's rather an approach to achieving an objective, and it's an approach that is that, as you heard, as we've all talked about today, it's applicable to different entities and different jurisdictions. So I think that's one of the key messages that does need to be reiterated, that public health is not the exclusive domain of ministries of health, or ministries even of public health. It is a means to an end that is collaboratively endorsed, and as we're seeing from the UK experience, one that the health sector in the UK does strongly support.
Sean, can I make a point? Excuse me. It is really important to say that there are barriers to the partnership on the part of a lot of people and organisations in the organised public health sector. Pardon me, excuse me. Some of those barriers are evidence-based, some of them are prejudiced and based on a lack of understanding. I have had personal experience dealing with a number of public health organisations at different levels of a real prejudice against police, where police are seen not to be part of the solution, but to be the problem. I'm terribly sorry. Now, the problem with that is that it's very easy to find evidence where police are part of the problem. And those, as I alluded to before, with police shootings of unarmed black men in the United States, for instance, those examples become magnified. It's important to recognise that policing is the most variable discipline, variable profession. I like saying that. I was talking to a group of police and others in New York once, and trying to talk about the working with police, the partnership in working with police. And I said, policing, I have met some of the most humane, caring, committed individuals I've ever met in police agencies. I've met some of the biggest fascist thugs I've ever met in police agencies. And I said, and they're not just in the same agency, sometimes they're in the same office. And a voice came to the audience and said, sometimes they're in the same car. And I thought that's a really good illustration of the fact that you're not dealing with a solid entity in terms of police. I've yet to meet a police agency in which there weren't at least a few police trying to explore doing things better. And I think it's up to public health to find and engage with those police. So where there's institutionalised prejudice or ignorance about the role of police, I think that's a real challenge for the public health sector to overcome and to reach out to engage with police. That's one. The other one is the issue I talked about before, about the fact that when something is criminalised, a lot of the public health sector turns its face away, doesn't look at it. That's a crime. It's not a public health issue. That's wrong. Just completely wrong. Those are two of the things that I think we need to deal with. And I'm laying the challenge there at the door of public health. The challenge is to all of us, but those are two areas where public health can take leadership.
Mm. I just want to quickly add just very quickly. I don't think we should be. I just want to add that ignorance and arrogance is not a trait that shouldn't be highlighted as a trait that is specific to policing agencies, but rather human nature. I think we could probably highlight just as many examples where they exist in any institution. So. But I do believe that sort of example, Nick, is that there is a stereotype, and there is a completely unrealistic stereotype in and of policing agencies. I almost work exclusively with police in my work, whether it's in violence reduction or in road safety, and the amount of time that I do hear about. I hear about the 0.0001% sort of example where there has been police corruption, and that fraction of a minority is what ends up tarring an entire discipline, rather than being seen in that way. And why we have that, why that microscopic focus gets applied only to policing rather than to any other public entity and public jurisdiction is something that I don't understand. I do think that police, of course, are open to public accountability, but we all are. As anyone working in a public space is open to such accountability, and I think all it does really is add to the pressure on police rather than serve a positive benefit. It's been a career privilege to work with the police that I have.
I think.
Can I make a couple of quick comments? Sorry, Justin, but just firstly, you're right. Arrogance and ignorance exist everywhere. But public health is supposed to be evidence-based. We should get our way out of that, firstly. Secondly, I think Justin would back me up. I think all of the people on this call would back me up in saying that the vast majority of people don't know what police do. I've had the conversation with leading figures in public health who say it's not about police, it's about getting the law right. If you get the law right, it automatically they see police as being automatic translators of law on the books to law on the streets. So you don't have to worry about police, you just have to get the law right. And I always respond to those by saying, if that's what you believe, then you've never spent any time on the street, mate.
Thank you. I'll go to Justin then, and then Jonathan for just a closing comment, if that's all right.
Okay, just picking up on both the Nick's points and Jonathan's. Certainly in the UK, I can't imagine it's any different globally. The police by far are the public sector agency that have the most media spotlight and media scrutiny. I would guess that's linked to the fact there's an awful lot of public interest in what the police do. That again takes us back to Nick's point around what do the police do and do the public understand it? Because a lot of the public think they see what they see on the television. They think it's about blue lights and pub fights. And actually, it's not. An awful lot of it takes us back to social determinants, health inequalities, mental health calls, and so on. 2:30 in the morning, often the police services globally are the phone call of choice. And therefore, we're having to pick those issues up when actually, in many ways, they'd be better served in a partnership landscape. And we're working with our partners. And that takes me, I suppose, back to my point that I wanted to raise, which is around, we talked before about trusted relationships and how important they are. Now, that's based on individuals. If we were able to look towards the future, we'd want a system that was adopting a public health approach. We'd want to be a system that climbed out of those silos. We'd want a system that shared data effectively, multi-agency data, to be able to paint those rich pictures in order so that we could deploy resources and do the right thing for our communities. We're not there yet. And that's the challenge for all of us, that to adopt a public health approach, it needs to be both a system lens as well as an individual lens. Because Helen talked about the fact that police officers, particularly senior police officers, get moved around a lot. You build a trusted relationship up and then the person gets moved on. So it can't be based around individuals. But from my experience, and certainly the senior leaders that I'm dealing with, there's an awful lot of appetite for doing something different. And the public health approach gives us something different that's cohesive and probably meets the needs of our communities today, because it deals with a whole plethora of things that impact on crime and impact on health outcomes and impact on lots of other things as well. So I think it gives us that real strong structure. It's a way of doing, it's a way of being, it's a cultural shift. It's not just for individual people on individual.
Thank you, Justin. And Jonathan, have you got anything you want to just finish us off with?
Yeah, thanks very much, Sean, and thank you for moderating this session. I'd like very much to thank my colleagues for joining this first panel, this first webinar that we've had on policing and public health, or public health and policing, depending on which side of that coin you fall on. I think this preliminary discussion highlights just how much there is to talk about. And certainly from our audience, I'd love to hear more about, are there particular topics, particular focuses in this area that we might organize future sessions on. Nick highlighted the growing and important resources that exist in the Global Law Enforcement and Public Health Association, and so I also hope that our audience can utilize those resources and references from the website that he shared with you. Reflecting on the content that Justin shared about adverse childhood experiences, I did want to take one quick opportunity just to highlight a few WHO resources on this issue, which is a few publications that were done in conjunction with Liverpool John Moores University, as well as the WHO Collaborating Centre at Bangor University. So we have this first one, a state-of-the-art report on adverse childhood experiences. We also have a handbook on how to prevent ACEs in the first place, but also develop resilience and preventing developing trauma-informed preventative and response systems. So I did just want to quickly share those resources which are available on Liverpool John Moores website. The Bangor University's website. So without, I think our first question. Oh no, I was about to say I thought our very first question might have popped up from the audience, but it's not a question. It's just it's a comment. Again, thank you all for joining us. Thank you for taking the time. We have recorded this session, so we will be sharing the recording of this information to all registered participants for further reference and feedback. All of the contact details are in that presentation, so if you have any questions or wish to follow up with any of our panelists, please do so. Thank you all and have a good rest of the day. Thank you.